Hello, and welcome to this Children's Nursing Development Unit Journal Club session. A particular warm welcome to anyone joining us for the first time. Are you watching this alone today, or have you gathered with a group of colleagues? If you are not with others today, consider gathering a group next time so that you can consider the questions provided at the end together. You may also be interested to know that you can access all our past journal clubs through our website. You can see the link here on the screen. You might find a journal article particularly of interest to you and your clinical setting. So for today, let's get going. This article is titled Impact of Structured Basic Life Support Course on Nurses' Cardiopulmonary Resuscitation Knowledge and Skills. Experience of a Pediatric Department in Low Resource Country. It was written by Umuhoza et al. And published in the African Journal of Emergency Medicine in 2021. Deaths occur in low-resource countries, especially sub-Saharan Africa. In Rwanda, acutely ill children are referred for higher levels of care, which means that tertiary hospitals like the University Teaching Hospital of Kigali, or CHUK, where this study was conducted, have a greater burden of acutely ill children that may go into cardiac arrest requiring resuscitation. Nurses are often the first at the scene. It is known that poorly skilled staff and life support are associated with increased morbidity and mortality among critically ill patients who have had cardiac arrest. Training on life support techniques can improve skills and knowledge to improve outcomes. However, skills decline quicker than knowledge, which speaks to the need for having frequent refresher courses to keep staff upskilled in resuscitation techniques. The timing of effective cardiopulmonary resuscitation, or CPR, is what determines the outcome in children arresting in hospital. In other words, the sooner CPR is started, the better the outcome for the child. This is especially true in low-resource settings where physician density is lower. So the aim of the study was to assess whether a limited, low-cost training intervention in basic life support would lead to a sustained increase in the basic life support knowledge and skills of pediatric nurses 6 months after training. Researchers used a prospective pre- and post-intervention study design. A prospective study is a study that follows a group of people, in this case nurses, over time. The study took place at the University Teaching Hospital of Kigali in Rwanda. CHUK is the largest tertiary hospital in Rwanda, serving pediatric and adult patients. The pediatric department receives over 300 patients per month and sees an average of 7 to 10 CPRs per week. Limited resources result in high mortality rates or poor outcomes for children who have suffered a cardiorespiratory arrest. All 80 nurses in the pediatric department were eligible and enrolled to participate in the study, with varied life support experience. The nurses that consented to participate were randomly divided into 10 groups according to their availability. A 4-hour basic life support training course was designed by the researchers, which they adapted for nurses in a resource-constrained environment. The intervention took place in the hospital simulation center and consisted of lectures, skill teaching sessions, as well as the assessment. The main objective of the training was to teach pediatric nurses to recognize pediatric emergencies through lectures, case discussions, demonstrations, and simulations. Aspects of the American Heart Association's basic life support training were used, but adapted to the local setting, which meant that teaching on automated external defibrillators, or AEDs, were excluded as this setting didn't have any of these devices available. The practical part of this intervention was a 2-hour interactive teaching session, and they used mannequins. There was no self-directed learning and no manual or course materials given to the nurses, but only face-to-face teaching took place and students were given the opportunity to practice these skills. The primary outcome was the nurses' skills and knowledge of basic life support before and after the intervention. Knowledge was tested with a pre- and post-intervention questionnaire, and skills were tested with a pre- and post-intervention scenario using a mannequin. The American Heart Association Infant CPR Checklist tool was used to measure skill accuracy. Remediation opportunities were afforded to participants whose efforts were found to be inadequate immediately after taking the test. Look at the analysis. Data was entered into Epidata and analyzed with Starter. Descriptive statistics were used to report the pre- and post-test findings and box plots to show the change in knowledge scores as seen in Figure 1. Various tests were used to compare intergroup comparisons, such as the paired t-test for paired numerical data, chi-square and Fisher-exact test for independent categorical data, and the McNemar test was used for paired ordinal categorical data. The demographics: 80 nurses were eligible to participate, however only 63 enrolled, but 6 left before the end of the study, leaving a total of 57 included in the final analysis as they completed the follow-up questionnaires. Basic life support knowledge scores increased from 58 to 83% immediately after the intervention, and then decreased to 76% 6 months later. The baseline or initial knowledge test showed a lack in basic life support knowledge, which was possibly because 33% of the nurses had received training more than 6 months before the training intervention took place, and the policy of yearly training had not been implemented yet. Demonstrated basic life support skills had also increased from baseline to immediately after the intervention. However, there was a variation in skill retention immediately post-intervention compared to 6 months later. All skills except the rate of chest compressions were improved at 6 months when compared to baseline. The nurses demonstrated poor skills prior to the training intervention, possibly because the role of nurses in CPR in Rwanda is generally passive. Although there was a decline in skills from immediately after training to 6 months later, skills were still better 6 months later than they were at baseline. Chest compression skills specifically were not retained, possibly because they were not practiced. Conclusion: there was a significant improvement in skills and knowledge immediately after the intervention, with retention of certain skills or knowledge at 6 months post-training. The authors therefore recommend debriefing and focused training after resuscitation episodes, as well as annual refresher courses for nurses to stay up to date. That's the end of the article, and I advise you to take a few moments to think about all that you have heard. Then turn to the reflective questions for this week. Think about how you could apply the results described in the article in your setting. How does your team stay up to date with current basic life support practices? Is there anything that could be changed about your current practice around basic life support? And finally, how would your team and the children you care for benefit from regular basic life support updates and training? Thank you for listening. I hope it was interesting to you and that you are excited to access the new Journal Club next month. Look out for its launch on our social media platforms. Bye for now!